right. And can you guys just see the PowerPoint?
Yes, looks good.
Okay, awesome. Okay, well, thank you. I'm excited to chat with everyone today. Thanks for having me. So, like I said, I'm Jenny Samiec. I'm the current addiction medicine fellow through UW. Um, and yeah, happy to be here talking with you all. Learning objectives. I'm going to start by saying this is a very, very big topic to cover. So we're going to do our best. Like Shannon mentioned earlier, it was previously two talks, and it might be best that way. But we're gonna tackle it. So today we're going to review the risks of chronic use of opioids and benzodiazepines, identify some patients who you might consider for a taper of these medications. We're going to explore the benefits and the risks of tapering these medications. We're going to review some current guidelines for a taper, and then we're going to talk about a couple of different adjunctive management strategies when tapering, both with medications and without. A little bit of background here. So these are just some fun ads I thought would be interesting to look at together. So we all see this all the time, especially in the primary care setting, just patients that have been prescribed opioids and benzodiazepines for many years, even decades. For a long time, they were marketed, as you can see here in the advertisements, marketed as safe, easy to dose, easy to titrate, beneficial, take care of your pain, take care of your anxiety, help her feel less anxious. You can see in that Sarax ad, those opioids, these ads here, that dates back to like the late 19th century. And we see the OxyContin there came probably more like early 2000s. Benzodiazepines, they appeared on the market in the 1960s and were kind of marketed as the safer option compared to barbiturates as a medication. And we see a nice little ad for Sarax and Ativan there. So just marketed as really good things to have for your patients, and definitely were used by providers who were trying to treat their patients. So these were kind of twin epidemics. We all know about the opioid epidemic. The benzodiazepine epidemic exists as well, so kind of alongside each other, actually. Prescription opioids from 1999 to 2010, they quadrupled. Pain was being marketed kind of as the fifth vital sign: need to address the pain, need to fix the pain. Here's an easy fix. We have opioids. Prescription by benzodiazepines, they actually increased by 67% from 1996 to 2013. The quantity of these actually more than tripled as well, quantity that was being prescribed to patients. So not only were they increased in just being prescribed in general, but people were getting more and more of them. Most commonly, they're used for anxiety, mood disorders, insomnia. And with this increase in the prescription of these two medications, we saw a concurrent increase in substance use disorders, overdose rates, among other issues that we will dive more into here in a minute. So benzodiazepines, they are a controlled substance. I think most people are familiar with opioids. I didn't make a special slide for that, but I wanted to review benzodiazepines in case people are not as familiar with which medications I'm referring to. They are a controlled substance in the sedative hypnotic anxiolytic class, meaning they are used and create sedation. They help with anxiety. They are a GABA A receptor agonist. GABA A is a transmitter in the brain. It kind of puts the brakes on things, helps slow down the brain, slow down the mind, the body. Also called a CNS, central nervous system depressant. So I just put some names here again so you can kind of familiarize yourself if you're not aware. But short acting, there are short, intermediate, and long acting benzodiazepines. The short acting ones are midazolam and triazolam, and they all have the azolam, so it can get confusing. But intermediate acting, we have the alprazolam, otherwise known as Xanax, lorazepam or Ativan, oxazepam, and temazepam. And then the long-acting are the diazepam or Valium, clonazepam or Klonopin, and chlordiazepoxide, also called Librium. And they're prescribed for a lot of different things, sometimes appropriate, sometimes not. Panic disorder, insomnia, anxiety, seizures, alcohol withdrawal, we use them commonly. And then for procedures when you need to induce amnesia. And then they're prescribed for agitation, commonly in the inpatient setting. Generally, short-term use is recommended, so for less than 4 weeks, unless there is an indication for long-term use, which they do exist. severe treatment-resistant anxiety disorder or bipolar disorder, complex seizure disorders, they're indicated spasticity, and then sleep disorders with abnormal movements. And then for end-of-life care, these medications are used, and that is appropriate. But generally, short-term use is recommended because of the risks associated with them. So moving into these risks, a lot of them overlap. Even some on the right and the left here that I've separated can kind of overlap to the other medication class. But for opioids, we worry about a slew of side effects. And risks: nausea, constipation, hormonal dysfunction, cardiovascular complications, sleep apnea, hyperalgesia, meaning increased pain over time with use of opioids, osteoporosis after chronic use, and immunosuppression. For benzodiazepines, even though they are used for sleep, they can actually cause disrupted sleep patterns, and they can cause mood changes over time, actually risk of suicidality with their use, memory loss, confusion, and just cognitive delay, motor incoordination, which can lead to falls, hip fractures, particularly a concern in the elderly population, and motor vehicle accidents. We know that people on benzodiazepines are at higher risk for getting in a motor vehicle accident. For both of these medications, we do worry about dizziness and falls, fatigue, respiratory depression, or slowing of the breathing, physical dependence, which of course we're going to talk a lot about today, and then risk of overdose. With benzodiazepines on their own, they rarely lead to an overdose, but once you talk about combining benzodiazepines with other CNS depressants, whether that's medication, such as opioids or alcohol, it is actually a high risk for overdose. Substance use disorders, and like I mentioned earlier, cognitive impairment can be a concern for with acute or chronic use of these medications. So here's a graph I wanted to go over. Risk. This is just this summary slide of risk for continued use, dependence on the medications, and substance use disorders. So on the left, you'll see a graph. This is from a MMWR publication where they went through the 1 and 3 year probabilities of continued opioid use among opioid naive patients based on the number of days of their first supply of opioid prescriptions. So this is pretty alarming. So you can see here that 1 year probability line is on the top, that dashed 3 year line probability is on the bottom. And, just for an example, looking at this, after just, 10 days of opioids, there's actually a 10% chance that that person will still be on opioids 3 years later, which is, a pretty significant percentage and pretty concerning. Once you go to a 30-day prescription, that risk of being on opioids 3 years later, quite a long time, goes to 20% chance. So we know that with use of these medications, it's common that they will be continued for a longer period of time than you might initially hope for. With opioids, the risk of developing opioid use disorder is 2 to 3 times higher for a prescription greater than 7 days. In this study, it was between 7 and 30 days of a prescription versus less than 7 days. And opioid use disorder development was 5.5 times higher for greater than 90 MME or morphine milliequivalents. So that's pretty significant. And then with benzodiazepines, 58 to 100% of patients who are prescribed benzodiazepines for greater than 1 month will become physically dependent. I would argue that that number is geared probably more towards 100%. If you're on benzodiazepines, especially daily for over a month, you're going to develop some level of physical dependence on these medications. Only 1.5% in this study would develop a benzodiazepine use disorder, which we'll talk about kind of what that looks like. And that is, the physical dependence for benzodiazepines and the use disorders more likely with, as you would expect, high doses and short-acting benzodiazepines, because they act quickly. They give kind of that quick rewarding feeling at times, euphoria feeling, and then they go away quickly. So the risk for just kind of needing more to get that same effect over time is higher. So, who might you consider a taper in? Pretty much anybody who is taking opioids or benzodiazepines regularly, should consider a taper. Now, this is obviously going to be more of a consideration when the risks outweigh the benefits of the medication. So that's the whole deal. You're discussing the risks and benefits of the medication, and you're also going to discuss the risks and benefits of a taper. So, when the risks of the medication outweigh the benefits, that might be if that person has high risk comorbidities. So, lung disease, including sleep apnea, kidney and liver disease, prolonged QTC interval, putting them at risk for cardiac complications, um, bipolar disorder, and suicidal ideation with a history of overdose. That is a risk for having these medications on hand, particularly if that overdose was with prescription medications. Or particularly for benzodiazepines, having PTSD as a comorbidity is, um, that's a risk factor for untreated PTSD. Actually, we know that PTSD is not as well treated when a person is taking benzodiazepines and can actually worsen their symptoms. Um, Concurrent use of opioids and benzodiazepines together is a concern, as I mentioned earlier, and then alcohol, other CNS depressants. For the elderly population, these medications are more dangerous. And then if the person has had an overdose or is displaying risky behaviors with these medications or non-adherence to the treatment plan, making you kind of concerns about how these medications are being used, you might consider getting them off just out of safety concern. If they're having a lot of adverse effects, particularly if these are falls or cognitive impairment, that's a big deal. If you have a concern for substance use disorder, you would want to consider tapering. If that is opioid use disorder, of course, a talk for another day, but you would want to consider actually agonist therapy like methadone or buprenorphine. And then if they're not having any reduction in pain or whatever symptom you may be treating, if the anxiety is not getting better with the medication, why are we continuing it? If they're not improving in function, patients, a good thing to do with them is identify goals when you're starting a medication. What do we hope to get out of this treatment? If we're not meeting that goal, we probably shouldn't be continuing that treatment. So an approach to a taper. So it's called the Bravo protocol. Actually, was created for tapering long-term opioid therapy, but many of the principles I think apply to tapering benzodiazepines as well. So that's why I wanted to kind of use it for this talk as a whole. So first, it's an acronym. I'm kind of big on acronyms, so it helped me. But so the B is for just broaching the subject with the patient when you're considering a taper. So it's a sensitive topic, right? These patients have been on these medications, again, sometimes for years or decades. And they are fearful of coming off of them. So you need to consider this carefully when you're thinking about bringing it up with the patient. It's not something you want to do when you're walking out the door. It's not something you want to do when you first met them. Ideally, you're involving the patient in the discussion. You're taking time for it. Ideally, its own appointment, which I realize in primary care is a challenge. And then again, just acknowledging that fear of losing the medication and going without it. But really taking the time to talk to them about what has been your experience with the medication. What are you going through? That kind of will bleed into the risk benefit calculation. So you're going to be talking to them about what benefits they're getting of the medication, what risks exist with them taking the medication, which you might have particular concerns in that patient. And you may bring up, hey, you don't have this risk or you don't have this, situation, side effect or complication yet, but this is what could happen in the future if we continue this. So that might be a discussion. And then again, risks and benefits of a taper as well, which we'll dive more into in a little bit. That kind of depends more to the specific medication. You want to do an addiction assessment. You can use the 4 C's for that, which I'm going to talk about in a second, to determine if you feel like they have a substance use disorder, which might change your management. And then V is for velocity, so that's speed of the taper, and then validation of the patient and their experience. So with these tapers, a huge thing to stress here is not abrupt discontinuation and being okay with this taking a lot of time. Like very commonly will take months to years, and that's okay. So it's really recommended to go slow for best success, to adjust the speed of your taper as needed. What you decide at the beginning may not be what you end up with. Even weeks or months, a month down the road, you might change the course. Um, and then just validating the patient's experience. So they might be ashamed to bring up to you what they're going through, whether it's worsening of their symptoms that you were trying to treat with that medication, or withdrawal symptoms. I mean, it's important to talk to them about what's expected with tapers and just validate their concerns when you follow up with them. And then other strategies. So we'll talk about adjunctive medications and behavioral interventions that can be helpful as you do this with patients. So real quick on an addiction assessment, many of you here, treat substance use disorders, of course, and maybe some of you don't, but I think it's important for everyone to be aware of how to identify them. And it can be confusing with these medications because, we're always trying to suss out, is this purely a physical dependence or is there truly a use disorder here? And I'm not going to lie, it can be very blurry. Sometimes it changes management, sometimes it doesn't. But it's important to just consider within your assessment. So C is for compulsive behavior of using the substance. So maybe using the medication despite trying to abstain from it and stop it. They feel like they have to have it. The next C is for continued use despite these negative consequences that they might be experiencing, whether that's a side effect, whether that's issues focusing at work, whether it's health issues, you name it, but they don't feel like they can get off the medication. Loss of control, taking more than they intended to, running out of the prescription early, cravings for the medication, feeling like they can't wait to get to that next dose, and then concerning behaviors with the medication would be part of this assessment as well. If you're concerned about again, taking more than they are supposed to, skipping days, needing those early refills, and maybe using for a different purpose than what was intended. For example, for the effect of altered mental status rather than just to treat the anxiety or the pain. They're actually using it to help with mood. That can be a concern. For substance use disorders and a prescription medication, you cannot use tolerance and withdrawal as criteria. Physical dependence is expected with these medications, as I mentioned. If you do have a substance use disorder that you suspect, it would be recommended to consider concurrent behavioral interventions. And then if it's opioid use disorder, like I mentioned earlier, considering agonist therapies like buprenorphine or methadone. And then, of course, addiction medicine is always here to help out if that's a question that you have. All right. And then, so here we're going to start with a case. I have two cases. One's opioids and one's benzodiazepine. So we're going to talk through these together and kind of apply those principles. So first we have Mr. O for our opioid case. So Mr. O, he's a 71-year-old male. He has sleep apnea, depression, chronic low back pain, for which he has been prescribed oxycodone for 7 years. He's currently taking 15 milligrams 6 times a day, which works out to be 135 MME. He reports worsening pain control, 7 or 8 out of 10 most days, and chronic fatigue. He tells you that he's frustrated with his life having to revolve around these medications. He's over it. He, has to take them everywhere he goes. He doesn't barely leave the house because of all that, stress. But he's afraid to go without it, as many are once you're on a medication for a long time. He also takes Tylenol, lisinopril, and then gabapentin, and he drinks 2 to 4 beers per week. Just looking at him right off the bat here, he's on 135 morphine equivalents. So anything over like 50 to especially over 90 morphine equivalents, the risk, their risk of complications, adverse effects, overdose, death, all of that goes up. So 135, we would want to be thinking about the fact that this is a really high dose and maybe he would benefit from a taper. And of course, he's having these other symptoms that he's concerned about related to the medication. So we're going to go through the Bravo protocol with Mr. O. So for broaching the subject, the taper had fortunately been previously mentioned at another visit. The time was set aside for this appointment to discuss today. in follow-up, and we reflected on Mr. O's experiences together. We acknowledged his anxiety surrounding the topic, and then we jumped into the risk-benefit calculation. So for him, he reports to you that, with opioids, he does get a small improvement in his pain. It is temporary, but it is there. And again, he doesn't feel like he can go without them. For risks of opioids, he's having some of these side effects. He's having increased pain, that hyperalgesia we know about, and he is using other CNS depressants with the gabapentin and alcohol use. He has developed a dependence on this medication. And then to top it off, he has sleep apnea, which is a high risk comorbidity to be prescribing opioids. So we talk about the benefits of tapering with him. Often we have studies that show patients actually experience improved pain control when you do get them off the full agonist opioid, and relief from hopefully relief from these other opioid related problems that he's experiencing, freedom from living by the pill, and then ideally improved quality of life, just being not kind of tied to this medication. Risk of the taper. So this is a big deal for both opioids and benzodiazepines, but patients need to know these risks when you're talking about tapering with them. So, of course, worsening of pain when you taper the medication that's theoretically been helping with their pain throughout this time, that pain can get worse. You can get withdrawal symptoms, which we'll go into in a bit. Psychological distress, including suicidal ideation, is a concern with tapering opioids. And then the risk of overdose, just because you lose some of that tolerance. And so the risk of overdose increases while you're tapering, because the person, again, has lost some of that tolerance to opioids. Most commonly, these symptoms, these risks are going to be a concern due to tapering too quickly. So really quick, tapering of opioids, risk of adverse events, we need to cover. So the CDC 2016 guidelines on prescribing opioids, they came out and they encouraged providers to weigh the benefits and risks of prescribing opioids and treating for chronic pain. And they explained why, they explained the risks of chronic use. And this was intended for for people to have these conversations with their patients about getting off the opioids. What this led to was a lot of fear and rapid tapers. Unfortunately, these recommendations were, somewhat misapplied, and people were kind of, whoa, I got to get my patient off this opioid. So they, rapid taper. Unfortunately, abrupt discontinuation probably occurred, leading to people going through opioid withdrawal. And then psychological harms with doing this. So there's a lot of harm, unfortunately, that came from this, even though we did see a decrease in the prescription of opioids, which ultimately we're hoping will help. People might have been doing that. People were doing that the wrong way, going too quickly, not, approaching it the right way with the patients. So there was a study in 2020 that kind of called this out. They called out the guidelines for not counseling patients on all these risks of harms, and they saw an increased risk of death from overdose, like I mentioned, is a possibility, or even suicide after stopping the long-term opioid treatment. They saw that this risk was higher when people were on opioids longer before they were stopped. That risk was highest in the first 3 months after tapering. They didn't really examine taper protocols or the context in which the opioid was stopped, so why it was stopped, what other situation was going on, and they didn't look at really how quickly it was done. But I imagine, a lot of reason for that, like I said, was going too fast. And then in 2019, and I put a picture of Narcan there just because we need to be prescribing Narcan to patients who are on opioids, just to have on hand in case of overdose, whether it's themselves and a family member can use the Narcan or somebody else. A 2019 study found a 7% risk reduction in opioid-related emergency room visits or hospitalizations, which with each additional week of tapering time prior to discontinuing. So this is just to say that doing this over a longer period of time, not tapering too quickly, is associated with a lower risk of adverse events overall. So we know that doing this more slowly can be helpful. And then we have the 2022 CDC guidelines that readdress some of these things. They actually wrote a whole article about how, hey, this maybe wasn't used in the best way, so now we're kind of changing our language a little bit. And they really emphasize the focus back toward the patient. So talked about shared decision making with tapering their medications, having that discussion with the patient. Um, Avoiding abrupt discontinuation, making that individualized plan with the person, and then being willing to adjust as needed to overall reduce risk with opioid use. So when they did say, when opioids are needed, prescribe these medications at the lowest effective dose and duration. Um, and then just an extra note here, non-opioid therapies are at least as effective as opioids for many common types, acute pain and chronic pain. And so just emphasizing here that with opioids, they are high risk to start. If we don't ever start them, we don't have to worry about stopping them. So they talked about weighing the risks and benefits of starting opioids even, and they talked about again the taper. These guidelines that were published, they were intended for situations outside of cancer-related pain, sickle cell disease, palliative care, end-of-life care. So not really considering those situations. That's a little bit handled differently. So back to our case with Mr. O. For him, when we started off seeing him, we had lower concern for opioid use disorder. He does follow his dosing schedule as prescribed. He's not having cravings for opioids. He says he doesn't have too many negative consequences that are, really severe in the moment. He is having the ones that we discussed, that have been developing over years. And he wants to stop. He wants to be done with the opioids. So then you move into the discussion with him about options for the pace of the taper with Mr. O. So anyone on daily opioids over a year, you want to go slowly. So you want to reduce by 5 to 10% of the original dose every month. Some will say 2 to 4 weeks, or even slower, sometimes slower than 5% every 4 weeks. I mean, you can go really slow depending on what the patient needs. If they're on opioids for less than a year, you might be able to go a little bit more quickly, maybe 10 to 20% every 2 to 4 weeks. Even that can be really fast. So it's always discussing that with the patient. If you have a safety concern, of course, you might want to go a little more quickly, or maybe the patient just prefers to be done with it, and you can go more quickly. And I think it's important to just counsel them on that risk that going fast is associated with, worse outcomes in many ways. If they are on a long and a short acting opioid together, that can get a little complicated. It's definitely an individualized approach with the patient. So, there is a higher risk of overdose on a long acting prescription. So often people will decide to taper that medication first. But it's really just talking with the patient about, hey, what do you think is helping you the most? What is going to be the hardest to let go of or go down on the dose? And I think it's having that discussion with them. There's not really strict recommendations on which to taper first. You talk to him, he wants to go down by 10% every month. That's where we start with him. So for him, you do want to go to other strategies. So other pain management strategies that you want to discuss with him would be non-opioid medications like NSAIDs, Tylenol, lidocaine patches, physical therapy if they're willing, massage, acupuncture, yoga, and then psychotherapy, mindfulness activities with pain can be very, very helpful. We have an excellent pain psychology course here at the VA that I think is awesome and can make a really big difference. And then opposite action skills. So that just means kind of encouraging the patient to act opposite to kind of what their emotional urge at the time. So say they don't feel like they can do anything, they have too much pain to take the dog for a walk, kind of just, I don't want to say mind over matter because that makes it sound too simple, but just to try to get, fake it till you make it. We'll put it that way. Take the dog for a walk. Just push yourself to do what you can tolerate, and try to kind of challenge your mindset because they might have been living in this mindset for years. And I think it's important to try to challenge that and try to be active as much as they can. But that can be hard. Pain's a tough one. And then just involving supportive family and friends is really helpful in this case. to have kind of their support in the process and be aware of what the patient might be going through. So he agrees to schedule Tylenol and practice mindfulness. So we're going to go into our sample taper with Mr. O. And I just want to say this taper is not meant to be, oh, you need to write this down and like this is exactly what you're going to do with the patient. Again, this is individualized. This is just an example and based on what the conversation with this patient was. So he starts off with oxycodone 15 milligrams 6 times a day. The first change you make is going down by 7.5 milligrams, which is the 8% reduction. You follow up with him after that first month, and he is having some more pain. Overall, he's doing well. He's okay with continuing that taper. He wants to get off of the medication. Second month, you'll go down by another 7.5. After this, he's a little more concerned. He's having some higher, increased pain, actually some runny nose and sweating. So maybe starting to see some withdrawal symptoms. We provide some education on that, validate the patient's symptoms, talk to him about that, and then talk about maybe what we can do differently. So how can we adjust the speed of the taper? How can we implement other strategies to help him out with the symptoms he's experiencing? So one point is that sometimes it can be helpful to keep the same dose cadence. So twice a day, 3 times a day, trying to keep that the same. The brain is used to getting the medication at certain times. So keeping that same dose can definitely be helpful. And again, involving the patient in which dose they might want to wean first. Slowing down, pausing the taper as needed. Ideally, you don't want to go backwards. You don't want to, go back on the progress they've already made. But again, that can be an individualized discussion. And then set expectations. Tell them what to expect. Symptoms often get worse before they improve. A lot of the time, that's going to include their pain. So with tapering opioids, we're monitoring for these symptoms of withdrawal. Opioid withdrawal, it's uncomfortable. It's rarely dangerous. But one of the big concerns with people with chronic pain is the increased pain. You kind of have to talk to them about that and what to expect, and just talk about how pain typically, it does return to baseline after 4 weeks on this new dose, or at least you expect that to be the case, because withdrawal from the medication is often what's causing that increased pain, not necessarily that the pain's getting worse. And then you want to look out for muscle aches, anxiety, nausea, runny nose, sweating, diarrhea, anxiety, insomnia, mood changes, dysphoria, and irritability, dilated pupils, goosebumps. These are all symptoms of opioid withdrawal. And there are medications listed on the right here that can help with those things. So antidiarrheal agents, maybe sleep aids like trazodone if it's a sleep problem. Clonidine can be very helpful for like anxiety and the sweating, like runny nose. And then for like anxiety, you can use hydroxyzine. And then of course, those medications for pain control. So NSAIDs, Tylenol, and things like that. So I had a just quick review of the first 2 months so you guys can see that here, but we move into month 3. So again, he was experiencing some withdrawal symptoms. So instead of an 8% reduction this time, we're going to go down by just 5% of that original dose and we're going to keep the 5 times a day this time. Last time we took away one of his 6th dose. So we're going to keep that 5 times a day, and we're going to go down by less. So go to 10 milligrams instead of all the way to 7.5. So we do that. We add some lidocaine patches. We give him some clonidine for the withdrawal symptoms, and he actually agrees to go to physical therapy. So we put that referral in, and he is doing better when you follow up with him. He's doing better with the smaller dose reduction and the other interventions. And then in the next couple months, you kind of continue those 5% reductions monthly, and he's doing well. And I just want to emphasize during this time, it is important to follow up frequently. It might look different for different patients, but you want to be routinely seeing them, assessing their pain, asking about their functional status, their quality of life, asking about their mood symptoms, screening for risk of suicidality, and ask if they are, going through with those other interventions that you talked about, like the Tylenol and the physical therapy and the mindfulness practices. You need to ask if they're doing that and not just have that conversation once. So you see him in follow-up after the end of month 6, and he's actually going on a trip with his brother, so he asked to pause that taper for a month. And you say, all right, no problem. He wants to not be in pain during their vacation, so you go ahead and pause it. We see him back at month 7 for follow-up, and he actually admits that during this time he supplemented his oxycodone with some of his brother's hydrocodone prescription, has been doing so for the past couple months, and he knows he shouldn't be doing this. He's tried to stop before, but the pain has been severe. And he has started to crave more medication. He stopped attending physical therapy, so it's interfering with his life, and he's pretty upset about this. So now at this point, we do have concern for opioid use disorder. He's using other medications. He's been using more, and actually has been doing this for, like I said, the past couple months, and not being upfront about that, of course, because there's a lot of shame involved from the patient's perspective. So now that we have that concern, we do discuss treatment. We talk about transition to buprenorphine, which is definitely a good option for opioid use disorder, and then continue other multimodal pain control behavioral interventions. So this is the end of this case, and I just want to summarize it by saying, ideally, yes, we can get patients off the opioids, and many will be successful in that. And it's important to continue monitoring them closely for signs of developing substance use disorder that you might not have detected earlier. So important to do that along the way. And then if you do have concern for opioid use disorder, talking about buprenorphine, methadone for treatment, um, and being okay with that. We're just trying to reduce the risk. And for opioid use disorder, we want to treat them. Even for chronic pain, if they cannot get all the way off of the opioids that they were taking, buprenorphine is an appropriate option for continued chronic pain management, and an effective option as well. So this is just a quick note on a resource for tapering opioids using the VA pain management opioid decision tool is really awesome, so that you guys can look up and use. There's also an HHS guide for clinicians on tapering opioids and how to go about that. This is just a screenshot on the right, and I believe this came from an AAFP article, and it goes through kind of the process of, first things first, you want to make sure is opioid use disorder present. If it is, you could switch to buprenorphine or methadone. If it's absent, then you can maybe start this taper, and then they give that example 10 to 20% every 4 weeks. Manage the withdrawal, emphasize the other strategies, constantly be reassessing function, pain control, quality of life, and opioid withdrawal symptoms. And then kind of you can follow the tree there. If those are adequately managed, continue tapering. They discontinue, they're doing well, great. Continue following up with them after they are done tapering. Continue assessing how they're doing is important. And if those symptoms are not managed well, again, being okay with adjusting the pace of the taper and continuing to use those adjunct options for tapering is very helpful. So yeah, we will go ahead and wrap up this case and move on to our benzo case. There will be time for questions, so we can go through that in a little bit. So tapering benzos, surprise, surprise, this is Ms. B. So for Ms. B, she's a 42-year-old female with PTSD. She's transitioning to you as her primary care physician. She was initially prescribed alprazolam or Xanax a little over 3 years ago for panic attacks. This was after losing a job, getting a divorce, and she actually takes 1 milligram of alprazolam 3 times a day. She notes feeling more depressed recently. She's not going out as much. Loud, crowded environments are often triggering for her PTSD. And she's actually mentioning that she's had, trouble concentrating for a couple of years now. She's wondering if she has ADHD. She's just a little confused on why she's feeling this way and, what's going on here. One thing, quick note on alprazolam, this medication is one of those that has a little bit of a shorter half-life, and it acts rapidly as well. It's a rapid onset of action, and so it's a high-risk medication that can lead to physical dependence more quickly than some of the other benzodiazepines, even within a couple of weeks. So broaching the subject with Miss B, we talk about gently, expressing this concern. And again, this is a new patient to us, right? So, she's transitioning as the PCP, so this needs to be done carefully. You need to make sure you try to establish some rapport, but also, address her concerns. So you express the concern that this dose is fairly high. You educate on the risks with long-term use of benzodiazepines, and express empathy for what she's going through. So She's having worsening depression. Her PTSD is not doing well. She's not going out as much. She's not living her life. Trouble concentrating and worried about, is this some other condition entirely? And you start talking to her about the benefits and the risks of taking the medication and of a taper. So for Miss B, her benefits that she's saying she has are the benzodiazepine, the alprazolam helps with sleep and anxiety. Um, and it's been useful for her at times, and she's obviously continued it for these years, so she thinks that there is benefit to them. However, we discussed that, could this trouble concentrating actually be from the medication, not necessarily another diagnosis? Is it, is the worsening of her depression and PTSD, is that from the alprazolam? We know that's an association with long-term use. And then we discussed the fact that it is lower efficacy of trauma-focused psychotherapy while a person's on a benzodiazepine and trying to treat their PTSD. Then we talk about the benefits of tapering. So for her, you would bring up maybe, hey, this could improve your thinking, your cognition. This might improve your anxiety and your sleep overall. We know benzo use long-term disrupts sleep patterns. And hopefully for her, she could have an improved quality of life, not being reliant on this medication 3 times a day, and hopefully freedom from some of these side effects that she's having. The risk of tapering is withdrawal, which with benzodiazepines, there is a little more of an actual, danger to that we'll discuss. Trouble sleeping, and then destabilization of her psychiatric conditions, risk of suicidality, and then increased mortality risk. So with that, the mortality, I put some stars there for the dangerous ones and the question mark by mortality. There was a study published by Mouse in 2023 that did call out a mortality risk in patients who discontinued their benzodiazepine use over a 6-month period. And that risk of mortality was 1.6 times higher compared to patients who continued use of the medication. The analysis didn't go into all the reasons for discontinuation or account for the rate of the discontinuation or how this was done, what other things were used. So it's hard to really say that taper is what caused that increased risk of mortality, but it's something to be aware of, that, just all the more evidence for that we need to be careful while we do this. So with Miss B, she's initially hesitant to taper. She's had intolerable anxiety in the past when she's run out and experiences this in between doses. You educate her on withdrawal symptoms and reassure her that you'll work with her to minimize these. She does not have a history of complicated withdrawal, which would be like seizures or delirium tremens, similar to alcohol. So withdrawal symptoms she might have, usually, within those first couple of days, she'll have increased anxiety, insomnia, restlessness. Moving forward, might have more irritability, still difficulty concentrating because there's a lot of changes going on, loss of appetite, again, sleep disturbances, and then rare but high risk withdrawal symptoms would be some other things like psychosis, definitely seizures or DTs, and then heart palpitations, panic attacks that could end up in an ER visit. So there are risks with this, and you need to assess the safety with benzodiazepines. She does not have any current signs of a benzo use disorder, so we're not concerned about that right now. Really quick, this table on determining the withdrawal risk. So if a patient is on the medication for longer, they're going to be higher risk for withdrawal, higher dose, higher risk for withdrawal. So this talks about the duration of benzodiazepine use, how many days a week, what's their total dose, what's their risk for withdrawal. Of course, more than 3 months, more than 4 days a week is the highest risk and going to be something you need to address as actually a possible safety concern. Not to say it can't be done still, but to make sure that you're counseling patient on the withdrawal symptoms and what to look out for and what might actually indicate like an ER visit. So with Ms. B, you recognize that tapering can worsen her existing PTSD symptoms. You guys consult with her psychiatrist and you come up with a taper strategy for her. You decide to decrease the dose by 5 to 10% every 2 to 4 weeks. That's just the general recommendation. So 5 to 10% every 2 to 4 weeks. You should not go faster than 25% in 2 weeks. You might need or lower doses for less amount of time. If they're on a lower dose for less than 3 months, you could maybe do a more rapid taper. If it's a short-acting benzodiazepine, you might consider a cross taper to a long-acting like clonazepam or diazepam. You do have to be careful in older adults and those with liver disease if you decide to do this, but it does make that transition off easier and lower risk. So you talk about transitioning to clonazepam with her, and she agrees to this. Not going to spend too much time here because I know we're cutting close to the end. But these are some dose equivalents. There are many tables, and it's not exact like morphine mill equivalents. And you can use that for the conversion to a longer acting medication. She agrees to engage in some psychosocial interventions. So she's going to do counseling. She's going to download the CBTI, which is an insomnia app through the VA, to help with this insomnia. And she's going to discuss healthy activity and food choices and talk about building social connections during this process, which can be really stressful. And then other medication options during a benzo taper, nothing is like a benzodiazepine. So you need to let them know that even these medications, they're not going to create the same effect, but they can just be helpful. So for like anxiety, hydroxyzine, gabapentin, or propranolol, clonidine, they can be useful. They're not going to create the same exact effect. And then just management of anxiety overall, like a daily medication, SSRI or SNRI. For insomnia, we have several options for sleep aids. We need to always talk about the risk with those as well, but they are options to help out during this time. So with her taper, we gradually over the first month go to clonazepam, eventually get to 1 milligram 3 times a day. She hasn't noticed too much of a difference with the change and did well with that. So by the end of week 4, we're on clonazepam 1 TID. Sorry, I'm going to rush through this part a little so we don't get bogged down in the details, but she's feeling well. She's feeling a little anxious about decreasing the dose, but wants to try. And so in the next few weeks, you start going down. You go down by 8%. She is having increased anxiety, difficulty sleeping, follows with a psychiatrist who actually starts her on sertraline and hydroxyzine for management of her PTSD and anxiety. And they increase the counseling visits. So both things that can help during this taper. So you pause the taper kind of while they're doing this. You agree, hey, it's okay. We're going to slow this down, let you get used to it, and you continue at that same dose. Fortunately for her, she's gradually tapered off the clonazepam and goes down just by 0.25 every couple of weeks with pauses as needed. And overall, this takes about 8 months. So again, it takes a long time to do this often. So toward the end there, the taper is slow to decrease by 0.125 every 4 to 6 weeks. So again, being flexible with decreasing the decrease and go a little more slowly. You follow up frequently and monitor her symptoms. She has made several behavioral changes to help with anxiety and sleep. PTSD symptoms improve, and she is going out more with friends and seeing some functional improvement. Fortunately, after a couple of years, she's able to stop the clonazepam entirely, and she's now stable on just the sertraline and hydroxyzine as needed, as well as therapy. Quick additional considerations. You could consider a blind taper. This, of course, has to be with the patient's consent, but decreasing the dose without telling them exactly what that decrease is. And then always remember indications for inpatient management, complicated withdrawal history, previously being unsuccessful, desire for a rapid taper because of significant harm or safety concerns, overdose history, psychiatric instability, lack of support, and then pregnancy, you might consider this. And then with pregnancy, with opioids and benzodiazepines, you want to weigh the risks and benefits of the taper that apply to both the mom and baby. So both opioids and benzos carry risk of fetal harm, but also the taper does as well. So you have to be aware of that. Risk for opioid use disorder, get them on agonist therapy. If you do taper, this needs to be done slowly, coordinate with the OB and pediatrician. Consider a higher level of care and close follow-up, and breastfeeding is encouraged during this as well. Last slide here, key points. So opioids and benzodiazepines, they have lots of risks with current use or with chronic use. If we don't start them, we don't need to stop them. So if we just consider that closely when you're considering starting these medications for a patient, that's ideal. So we don't need to eventually worry about tapering them. And they don't have to worry about all the things that come with chronic use. It's really recommended to be gradual and flexible with this. Often will take months to years. Everybody's different, so be aware that not every person is going to be the same here. What works for one person might not work for someone else. Remember to use those psychosocial interventions and adjunctive medications to help you out and help the patient out, most importantly, and then regularly follow up, revisit their goals often. Remember that if they cannot get off entirely, that lower dose is still better. So the more you can get them down and reduce the risk, that is better than not doing it at all. So they, that's going to be patient dependent. So make sure to follow up after you're done tapering as well, and continue to assess all these things. So that is all I got. Sorry that we're cutting close on time, but I'm happy to take questions or comments or anything to add.
Thanks, Jenny. You can go ahead and stop your share.
Okay, do that.
We have time for maybe one question. Is there anybody who has a burning question here that they'd like to ask or comment?
I'd like to hear Dr. Hayden's take on the benzo tapering. It's an interesting topic, and he always has interesting takes on that. Derek, you just put that message in there about how it was overstated. So I was just wondering if you could.
Yeah, I'd be happy to just talk for 1 minute about it. So that study in 2023, so it's an observational study, and so they're looking at things with de-identified insurance information, and so they don't know anything else about it. They don't know why the benzo was stopped. They don't know if somebody was chronically ill and they were dying from something else, or if they were using other substances. And so you really don't know anything other than after the fact what happened, but not why. And so it introduces all kinds of biases, like survivorship biases, immortal time bias. I mean, these are all kind of, it would take a long time to explain them, but but it's just not a very good study for that reason. I mean, it's a curious study. It wasn't poorly done, but I think the conclusion that's drawn from it is maybe not supported. And even the authors noted in their their commentary that this is at odds with the data that exists from randomized controlled trials. And so I don't think that we should change our practice based off of that study. I think that the best evidence is still that benzodiazepines have known harms, and we should taper them as much as clinically able.
Thanks.
Thanks, Derek. And thanks for clarifying that. Great addition there. Jenny, awesome job. This was a really big presentation that you had to do in 50 minutes. So thank you so much for putting this together. This was great. We will have the recording up on our website. The slides are already there. And then, of course, if you have any cases, we have that opening on May 14th. So if you are a prescriber and you have cases related to substance use, please reach out to me, and we will get you scheduled on there. Our next session is going to be Thursday, March 26th from noon to 1 p.m. We have Amber LaRocco, who's an addiction and alcohol and drug counselor and the grant program manager with Trivium Life Services. She will be presenting on risk reduction and community overdose prevention. So hope to see you then. Thanks, everybody. Have a great rest of your day.